published several studies about liver stiffness measurement, and also he has a great experience about liver steatosis assessment with different ultrasound devices. So he will share with you his experience with G technologies related to these clinical topics. After his presentation, we will continue our liver care journey in direct from Germany with Ms. Anke Dobrowski, who is Senior Clinical Specialist for G ultrasound, and she will perform a live scanning where she will show you a comprehensive overview about the logic E10 solution along the liver care pathway. Of course, take the opportunity during the session to share with us your question, and Dr. Cassinotto and Anke will answer at the end. So now it's time for me to wish you a very nice session, and I hand over to Dr. Cassinotto. Thank you.
Okay, dear ladies and gentlemen, good afternoon. I'm Dr. Christophe Cassinotto from Montpellier University Hospital in France. I'm very pleased to share with you today our experience with multiparametric ultrasound in clinical practice, and especially in chronic liver diseases management. So in this talk, we will deal mainly with two recent diagnostic tools that have been implemented on the Logic E10 device. First, the bidimensional shear-wave elastography module that performs an estimation of the liver stiffness, and second, the UGAP for ultrasound-guided attenuation parameter module that gives an estimation of the liver fat content. I've tried to focus on practical, simple, and clear messages that I hope will be helpful for your clinical practice. First question is how to perform measurements. All these conditions on the right of the screen have to be met when you perform liver stiffness measurement. Patient should be fasting, lying in a supine position with the right arm in abduction to enlarge the right intercostal space. You will target the right liver lobe of the liver through right intercostal spaces with the liver capsula displayed horizontally, and importantly, you will look for the best quality, the best resolution ultrasound images without any shadowing or any large vessels. So to that purpose, you will look for the smallest intercostal wall thickness, and very importantly, you should press hard on the probe. For the positioning of the ROI, it's at least 1 centimeter below the liver capsula, but staying superficial in order to get more reproducibility. And you will perform your measurement by block of breathing or during short apnea. As you can see on the motion, the video on the left part of the screen, this is a real-time video, and it's quite easy and fast to perform 10 liver stiffness measurements. In less than 2 minutes, with a little bit of training, you can perform 10 liver stiffness measurements and 10 UGAP measurements on the patient. And at the end, the device will automatically deliver the results with the median of the 10 measurements and the interquartile range and the interquartile range above median value ratio. Before interpreting the results of your liver stiffness measurement, we have to be aware of some important precautions of use. The first notion to apprehend is that in few years, a multitude of non-invasive diagnostic tests have appeared in the field of liver diseases. These tests can be clinical, laboratory tests with indirect or direct biomarkers, composite tests, and now also many physical tests like fibroscan, shear wave elastography, or all the new possibilities of MR imaging. As a consequence, we have to acknowledge that most of the times, definitive conclusions won't be drawn from a single examination. Actually, the hepatologist will assess our results along with the history, the clinical data, the lab test, the liver fibrosis serum test, and sometimes also with a second liver stiffness value with fibroscan or MR elastography. It is therefore delicate to want absolutely to give a definitive conclusion after only a single measurement on a single examination. Second very important point is that liver stiffness is not equal to liver fibrosis. This is probably one of the best non-invasive diagnostic tools to assess the fibrosis stage, but it remains an independent entity, an entire parameter with many confounding factors, such as cholestasis, portal inflow, outflow obstruction, or inflammation. Two of them specifically inflammation during active hepatitis or outflow obstruction can cause a huge increase of liver stiffness values. It means that a patient with an autoimmune hepatitis may have 15 kPa or even more, 30, 50 kPa of liver stiffness without any fibrosis, just inflammation. The same for patient with a strong and recent alcohol intake. He or she may have very increased liver stiffness values just because of massive inflammation due to acute hepatitis. It doesn't mean that liver stiffness is not interesting in this case. For this patient, it may even be used to follow a patient once the disease is cured, but we should be aware of that confounding factors. So second take-home message is that we have to pay attention to confounding factors, and here again, we have to consider that the hepatologist will assess our results along with the history and all the other clinical and laboratory data. A third precaution of use is that some technical factors can impair the quality of the ultrasound image and lead to false increased values. Most of the time, these factors are related to obesity that will be responsible for poor acoustic window and an increased parietal wall thickness. But sometimes it can just be dyspnea or an advanced age of the patient. In these cases, it is important to take time to look for the best acoustic window, to find the smallest parietal thickness in the intercostal chest wall, and to press hard on the probe. And sometimes falsely increased measurements are obvious, like on the top image, but sometimes it's more confusing or delicate, like on the image down. It will just be few values around 5, others at 8 or sometimes 10 kPa. So an important message is that we have to precise in our reports how confident we are in the liver stiffness value. By putting systematically the interquartile range above median value ratio, or by being honest and informing our clinician if we have difficulties in obtaining reproducible values, and sometimes by avoiding giving values and considering it as false measurements. It's important to understand that a false increased values can have bad consequences for a patient, and it's clearly better to give nothing than to give an inaccurate value. So this concern leads us to a very practical questions: how to report. In my opinion, there are two different situations. First, the US examination was asked by a liver specialized practitioner. Hepatologists know the normal range of values of liver stiffness, and they specifically know how to interpret these values. So in this case, I don't give any conclusions. I just report the liver stiffness median, the IQR median ratio, and the device of the technique that was used. The second situation is when US examination was asked by a non-specialized practitioner. In this case, I just precise if the value is strictly normal or was slightly or moderately or highly elevated. And always according to the context, when it is an increased value, we propose a consultation with a liver specialized clinician. You will notice that in any cases, we don't give a liver fibrosis stage because this is not the point in clinical practice. So if it's not the point, what are the clinical applications of liver stiffness? Liver stiffness is a comprehensive and independent parameter that has many other applications. Mainly regarding chronic liver diseases, it will be used for the diagnosis or the screening of advanced chronic liver disease, for the assessment of severity of portal hypertension and its risk of complications, for the longitudinal follow-up of patients, and even at the diagnosis for the prognosis of patients. So we won't have time in this talk to develop all these bullets, but I spent some time on the first point, the diagnosis and screening of advanced chronic liver disease. You know the natural history of chronic liver diseases. After grossly 20-25 years of chronic liver injury, such as alcohol, viral hepatitis, or steatosis, patients will start developing fibrotic and inflammatory lesions, to eventually, after many more years, develop compensated then decompensated cirrhosis. This is important to understand that this is a continuum disease with some overlapping between stages and sometimes some resilience if the cause of the liver injury has been cured. You can notice that except if patients develop HCC or decompensated cirrhosis, they will remain asymptomatic for a very long time. This is where elastography has an important role to play by detecting patients still asymptomatic but at risk of developing clinically significant portal hypertension, which has been defined in an expert consensus called Baveno 6 criteria as patient with at least severe fibrosis. And this spectrum of disease has been named compensated advanced chronic liver disease. In 2015, in a study published in a consensus published in Journal of Hepatology, the cutoff for ruling in and ruling out advanced chronic liver disease were empirically set at 10 and 15 kPa for FibroScan. In a recent European study performed on more than 5,600 patients with the liver biopsy, they refine these cutoffs at 8 and 12 kPa for ruling out and ruling in ACLD with a sensitivity and specificity of more than 80%. And between both, a gray zone with unclassified patients who will need further examinations. The way hepatologists use liver elastography for their clinical practice is very interesting. Based on liver biopsy, they set a liver elastography definition of a new concept, which is ACLD, and with the main objective of no longer referring to fibrosis stage and histology. This is really how we have to appreciate the clinical utility of liver stiffness. Now that liver elastography has been proved to be efficient to detect advanced chronic liver diseases, and that acceptable cutoff has been set off, many questions remain on how to implement this diagnostic tool for the screening of ACLD in a general or at-risk population. More and more studies have recently been performed on the different strategies that can be proposed to that purpose. In particular, strategies using a simple and low-cost biological fibrosis test, such as FIB4 at first step, and a complementary use of shear-wave elastography and FibroScan at next steps seem to be very promising. And very interestingly, in such strategies, shear-wave elastography and FibroScan are not seen as concurrent, but as complementary tools. The second quantitative tool proposed on the Logic E10 device is the ultrasound-guided attenuation parameter. As for liver elastography, this is very simple and quick to perform 10 measurements and to record the final chart with the median and interquartile range of the measurements. To understand the importance of the quantification of the liver fat content, we have to take insight into the non-alcoholic fatty liver disease. This disease is a hepatic expression of metabolic syndrome represented by an excessive liver fat accumulation of more than 5% within the hepatocytes. This disease is clearly the future of pathology, being the first cause of chronic liver diseases now in the West. Hopefully, it will have an impact on morbid mortality only if it changes, if evolution towards steatohepatitis. So there are still a pivotal role of liver stiffness to detect fibrotic and inflammatory lesions. So the question is, why to quantify a liver steatosis? There are two main reasons. The first one is to diagnose NAFLD, and so to check for patients who should be screened and follow up for the appearance of liver fibrosis. And the second important point is for performing a longitudinal follow-up of patients who have liver steatosis. Ultrasound-guided attenuation parameter is a recent diagnostic tool that has been developed to that purpose. Attenuation is a energy loss of the ultrasound wave caused by reflection, scattering, and absorption. The first tool that have been proposed to assess steatosis using ultrasound attenuation was the CAP for controlled attenuation parameter, an additional tool implemented on the FibroScan. If this tool was a pioneer in the field, its diagnostic performances remain limited. Regarding the diagnostic performances of UGAP, it's still a little early to be certain. However, in two preliminary studies, as in our still unpublished experience based on 150 patients who had UGAP and MRI-PDFF on the same day, the EUROC values were around or above 0.90 for the diagnosis of at least S1 and at least S2 steatosis grade, which is clearly very promising. In conclusion, regarding liver bidimensional shear-wave elastography, this is a very powerful diagnostic and prognostic entity. It has a pivotal role to play in the diagnosis of screening of advanced liver diseases. Many clinical applications, but no need to limit it to a fibrosis stage. And we should apprehend the limitations and confounding factors of the technique. Regarding ultrasound-guided attenuation parameter, here again, this is a very promising diagnostic tool with promising diagnostic performances, and it is an essential complement to the multi-parametric exploration of the liver using ultrasonography. Thank you very much for your attention.
Thank you, Dr. Cassinotto, for your presentation. I think through your experience, we were able clearly to understand the role of 2D shear wave elastography in the assessment of liver fibrosis, but also the key role of UGAP technology to quantify the liver steatosis. And also, you share with us a very interesting information regarding the way to interpret the result and also about the precaution of use for these both technologies. So thank you for the time and also your experience sharing today. So now let's move all together virtually in Germany, where Anke is going to perform a live scanning about Logic E10 performance in a liver investigation. So enjoy.
Hello. Welcome to our Logic E10 presentation out of Germany. And welcome to GE Healthcare at ECR 2021. Remember, in 2018, we launched the Logic E10. Logic E10 is a system for today, as well as a platform for tomorrow. With our presentation, we would like to give you an update on solutions for your daily routine. We as GE are constantly working on improvements to provide you high level of concise workflow. We as GE are providing comprehensive tools which supports you in your diagnosis. And finally, we as GE are focusing on increasing the level of confident diagnosis. Let's have a look at the system itself, dedicated to liver diagnosis. Logic E10 is based on C-Sound image format technology. C-Sound image format technology acquires and proceeds ultrasound data differently. The acquisition is faster and the data throughput is much higher. But what does it mean to you as a user? Let's start with the 2D liver by using the C126D XT Clear probe. I believe it's easy to see that immediately we fulfill the high standard of image quality. We have a high level of contrast resolution, high level of spatial resolution, for example, here the tiny vessels, great image uniformity from the near field to the far field, and finally, a great penetration. In this case, we are scanning up to 15 centimeters by using 6 megahertz. Let's move to color Doppler. 2D image quality is very important, but remember, in liver diagnosis, you also need to have a fast and precise color Doppler performance. And color Doppler examination can be challenging with very different patient pathologies. While activating the color Doppler, you will see that the high level of 2D image quality remains. You can also increase the region of interest if needed. The color stays in the vessel. And if needed and if seen, you can nicely see small, tiny vessels and great vessel separation. If you want, you can easily activate live simultaneous dual view, which means you see on the left-hand side liver texture, as well as on the right-hand side vascularity information, for example, for stenosis diagnosis. Let's enable microvascular imaging. Stop breathing, please. Microvascular imaging is dedicated for very tiny vessels. And you can see here the image in combination with radiant flow, an algorithm which provides you a 3D appearance and increases the definition of vessel borders. Okay, breathe out. Shear wave elastography. Let's go back to the presentation of Dr. Casinotto about shear wave and ultrasound guided attenuation parameter. As you know, 2D shear wave elastography is an advanced technique that provides quantitative as well as qualitative analysis of stiffness. In our case, liver tissue, to stage the liver fibrosis. After positioning the patient and the transducer, you can have on the left side the quality indicator, and at the same time on the right-hand side the elastogram itself. You can select between different acquisition types. In this case, I would like to show you the multiple measurement option. Please stop breathing. You see, the system now is acquiring several measurements. Now I go on freeze, and the system immediately offers you the measurements. You can accept the measurements or skip. Let's accept. You will see on the left-hand side our worksheet, and the measurements are shown in kilopascal as well as in meter per second. Here I would like to point out the very fast workflow. You see on the worksheet as well the IQR and the median. Let's move to ultrasound guided attenuation parameter. UGAP is a real-time image-guided method to quantify the attenuation of the sound wave in liver tissues due to steatosis. The preparation of the patient, as well as the concise workflow, is very close to the shear wave acquisition we just went over. I will now activate UGAP. In the middle, you see the region of interest. You can either add the quality map. Quality map is corresponding to the measurement accuracy, while attenuation map, the color corresponds to the attenuation measurement, to the attenuation values. Like in shear wave, you can choose two different types of acquisition. If needed, you can have the dual view in addition. So please stop breathing. Now we are acquiring our UGAP measurements. And freeze. And you will see here in the middle the measurement, and below on the monitor the values. You can accept. If the system is not, if the measurement is not acceptable, the system will tell you immediately that you cannot use this measurement. After my live presentation, I would like to point out some additional images and comprehensive tools we are providing for liver diagnosis. Please have a look at my screen. This is C-Sound image format. You can see every pixel is in focus. For liver diagnosis, we are providing auto lesion segmentation. Auto lesion segmentation is an advanced tool for having easier, concise workflow. Go to measurement. You're activating auto tour. And the system offers you immediately the size of the lesion. This is based on artificial intelligence. As a next, I would like to point out our contrast-enhanced ultrasound. With contrast-enhanced ultrasound, we are providing different types of technique, the amplitude modulation, as well as phase inversion technique. With our Logic E10 system, you can now combine microvascular imaging during your contrast examination. For sure, we are providing parametric imaging. And finally, to complete the liver examination with Logic E10, we are providing volume navigation. Here on this case, you can see we add to our 2D on the left-hand side the contrast-enhanced ultrasound. So it is volume navigation plus contrast-enhanced ultrasound at the same time. The last image is a case of B-flow technology. We did with the Logic E10 a lot of enhancements to this technology. Thanks for watching my presentation, and now I will hand over back to Frick.
I hope you enjoyed this live scanning session. Thank you, Anke, for your great demonstration. And your way to present the logic E10 performance through the liver care area. So now I'd like to review with you some questions we collected during the session. And the first question is for you, Dr. Cassinotto. In case of heterogeneous liver, where should we do the shear wave and UGAP measurement? Do you recommend this segment 3 or 4?
Yeah, it's an interesting question. Hopefully, it's not often the case. In many patients, you don't have a clear heterogeneous distribution of the liver fat content. In these patients, usually I perform the measurements where the quality of the ultrasound image is the best. So I don't try to target a specifically area. We just go where we think that we will be more reproducible. However, if you have a patient with a real difference in echogenicity, you can try to make measurements at different locations. But for liver stiffness, you always have to stay on the right liver lobe, or specifically via through right intercostal spaces. You never go in an epigastric approach because you will falsely increase your values. This is not the case for UGAPE, where you can go, if you want, on the left liver lobe, segment 3, segment 4, if you want, or on the right lobe.
Thank you, Dr. Cassinotto, for your answer. So the second question is still for you, Dr. Cassinotto. Is there any difference in the patient management for chronic liver disease between a private cabinet and the hospital? And which kind of patient?
Yeah, I see what you mean. No, there are no special differences. The main differences are that the way you interpret your values depends on the clinician who asks for the liver elastography measurements, and you will be more helpful, or you will be more affirmative if the patient is sent by a general practitioner because you want to help him. Regarding the question of to which patients you have to perform systematically a liver elastography measurement, I would say that the more patients you perform it, the best it is. For sure, you won't perform, if you don't have time, a liver stiffness measurement for a young patient who comes in your cabinet or department for just a vague abdominal pain. But when the patient, especially if he is or she is above 40, 45 years, have one of several risk factors of chronic liver disease, and by that I mean diabetes, obesity, for sure viral hepatitis, a moderate alcohol consumption, even not a huge alcohol consumption, just a regular alcohol consumption. All these patients should have systematically a liver stiffness measurement performed, for sure.
Thank you, Dr. Cassinotto, for your answer to this complex question. So the last question is for you, Anke, and it is related to your live demonstration. It is about probe. So the question is, does GE have some dedicated interventional probe for liver surgical procedure?
Thank you, Fred. Yes, it's a very interesting question. We do provide probes for interventional procedures. If you have a second, I would like to show you some cases. So on one hand, we do provide images, we do provide a transducer, the C226B probe, so it's a dedicated biopsy probe. And finally, we do provide a L329 eye probe. It's a interoperative probe. Here you can see some nice images and the strength of this transducer. And for sure, for your interventional procedure, you can also add contrast-enhanced ultrasound on the L329 eye probe. Thank you. So I believe I will now hand over to you, Fred.
Many thanks for your answer to this relevant question, Dr. Cassinotto and Anke. So thank you. And I hope all participants enjoyed the session today. Let's continue tomorrow. Tomorrow we'll talk about vascular imaging with Dr. Liazis and also live scanning done by Anke. So I hope you enjoyed today. I wish you a very nice day. Stay safe and of course enjoy ECR 2021. Bye-bye. Thank you.
Hold up.